How much does sperm really cost? And does pineapple really help implantation? If you've ever Googled those questions, you're not alone. Fertility is full of myths, half-truths, and a lot of mystery. I'm Dr. Jay Rutland, and today on The Health Exchange, we're joined by Dr. Sasha Hackman, board-certified OB-GYN and reproductive endocrinologist, and the host of the Trying to Conceive podcast. We're exploring everything from the basics of fertility to advanced treatments like IVF and separating fact from fiction. Let's get into it. So thanks again, Sasha, for coming. I really appreciate it. There are lots of fascinating things in fertility. It's a field where hope, stress, and excitement kind of all collide in an office or in front of you, right?
Yeah, all the time.
What drove you to REI?
It's kind of a long story, but if I were to summarize it, ironically, when I was in medical school, I went in with the intention to become a general surgeon who then specializes in breast surgery. So I always knew I wanted to do something with women's health, but I wanted to actually focus more on breast cancer. When I rotated through general surgery, even though I loved being in the OR and I didn't mind the crazy hours, and we were given a lot of responsibility even as medical students during that rotation, I don't know, I just didn't love the culture. And as a med student, the culture that you witness in your rotations heavily influences the specialty you end up selecting to go into. And my OBGYN rotation was so much fun. I rotated where I ended up doing my residency through Michigan State. And it was kind of like a sorority. Everyone was really friendly with one another. And they really wanted you to learn. If you were excited about the specialty, they gave you a lot of opportunity to do hands-on things with patients, get involved. And so I loved it. And I was like, I could do gynecologic surgeries. My goal is to go into gynecology oncology.
Oh, yeah.
But I kind of found it to be very somber, heavy, sad, although I really respect the field and I love it. I think they're doing incredible work. I found that as I started to kind of get to know myself in the medical field, it's like, man, I really like basic science and I like innovation. And as a resident, which is really rare, I was doing a lot of bench work, basic science research. I'd finish a 14-hour day, then go to a local university that I had been collaborating with to do stem cell research and other research on toxins and how they affect egg quality on mouse oocytes.
Wow.
So that's how I ended up going to REI.
I loved OB-GYN, and when I rotated, I was like, dude, I want to do this.
That's amazing.
I loved it because there was imaging, there was procedures, there was clinic, all of that stuff.
Everything.
You get everything,
Yes.
right? I picked pulmonary critical care because for me, it was kind of the same thing where I could do so many different things. And it sounds like, you got energy from being able to change your focus. First you're doing a procedure, then you're in clinic, then you're thinking medically about what's going on. And I guess in your field, we're going to get into hormones and things like that.
Yeah.
Was there a patient story that you had during your rotation that had an impact on you?
So as residents, we had a resident clinic, and so we would see our own patients. Most of them were Medicaid, more underserved communities. And there's this one patient in particular who came to see me, and she was talking about the fact how she's been trying to get pregnant for over a year. It wasn't happening, and she couldn't afford to go see a fertility doctor since most fertility clinics are cash pay or, PPO type insurance. And so in her case, I did some imaging, I scanned her, and I got a thorough history, and she had a prior second trimester abortion. And sometimes they use laminaria to help induce cervical dilation, which is basically seaweed sticks. And
Wait, laminaria are seaweed sticks?
yeah, basically.
And wait, how does the seaweed stick work?
So through osmosis.
Wow.
So yeah, it basically pulls that fluid, and so it helps dilate the cervix. Somehow, some way, whoever had done it left it there, and it migrated fully into the uterine cavity, and that was 10 years prior. And so it completely scarred into her cavity. She had an obliterated uterine cavity. And so the reason she wasn't getting pregnant is there was nowhere for implantation to occur. And so I said, listen, this is a little bit far-fetched. I said, if you trust me, let's try and do this. We're through hormone therapy. I'm going to rebuild your lining with estrogen.
Did you take it out?
And then we're going to go in surgically and I'm going to try to remove everything I can. It wasn't one solid piece just to remove. I wish it was. It was basically completely integrated. And so I couldn't even figure out her anatomy, but under ultrasound guidance, I was able to remove bits and pieces of all of this extra tissue. And the pathology report came back showing algae type products, confirming my suspicion. And it was just all based on my suspicion. And we had to do multiple revision surgeries to undo her Asherman syndrome. But eventually she was able to resume menstrual cycles and get pregnant, which was insane. I couldn't even believe it, right, as I was graduating. And so I was like, wow, I literally changed the course of her family life by just doing these procedures and trying until we got to where we could go, because I knew that she would never be able to afford IVF with a gestational carrier that costs 6 figures, and the majority of people can't access that kind of finances for treatment. So
You changed the course of her life because you listened. A lot of us in training, we're so busy, and like we hear people, but we don't
yeah.
listen as much as we should. And you sat there and you listened to her. And just by that, you were like, you know what? You do the ultrasound, sounds like you have a working diagnosis. And then again, because of the field that you were involved in,
Yeah.
you were able to do the definitive thing. And that's a powerful thing. That's a powerful story.
I mean, it felt incredibly rewarding, and just seeing how grateful she was. And there is nothing more stressful than really wanting a baby and not being able to have a baby. And as a woman, like, and as someone who's gone through infertility myself, it just feels like you're losing that femininity, like your whole almost for many of us, we feel like it's a big part of our purpose. And if you can't achieve that, you feel very lost.
How have you seen your field of REI evolve over your career?
It's actually evolved quite a bit from two different perspectives. From a business point of view, it has evolved as a specialty, but then also the science behind it all. We are definitely improving in our success rates, what we have available, the technology, and now use of artificial intelligence to try to maximize and increase our success rates.
How does AI help you increase your success rates? What are you guys using it for?
So we're using it in various different aspects of assisted reproduction specifically. So if we're talking about IVF, we can use it to analyze sperm better, help select the best sperm projected by AI. It can help us give more information about the egg. Now, mind you, all of this is in its infancy, and so we definitely have a lot of growth to do still. Some people will argue that it shouldn't really be out in the market until it's been really rigorously validated, and that's something that we lack in our field overall, where as soon as something is available or something has been internally validated without clinical trials, it is out in the market. But I think it's because a lot of patients will see, hey, there's this new tech available. I want to tap into it. I don't want to wait until you get millions of dollars in funding from, whatever grants or the NIH or the government, which is clearly not, providing enough research funds in women's health in general and in particular in infertility. So patients want to tap into that, so they're using it. We're using AI to analyze embryo development because we have time-lapse incubators that can actually look at the cellular division of the embryo and then even give a score of whatever embryos are in that incubator, from like the top embryo that is expected to perform to the least likely to perform in that batch.
That's amazing.
It's amazing. It is amazing.
So I know how you got to where you are now. I want to do a little fertility 101. I want
Okay.
to talk about
Love it.
what it is. And I want you to let our listeners know what it is, what's going on, what needs to happen. So take me through the fertility timeline.
So if we're talking traditional timelines, the basic definition of infertility is 12 months of unprotected sex with no conception, as long as you're having regular intercourse.
What is that?
So
What's regular intercourse? Like, I mean, I've heard people say
a
that
couple times a week.
2 times a week.
A couple times a week. I mean, there's no set definition of what adequate intercourse is,
Yeah.
but if somebody's telling me that they're having sex once a month, that's not enough sex.
Okay.
It's just not. And especially if you're not tracking to see what your fertile window is, then you might not be hitting the mark. But if somebody is having sex at least weekly, maybe a couple times a week, and it hasn't happened after a year, then that's sort of a red flag. Or if somebody is tracking their ovulation to at least time sex during the fertile window because they understand how that works, that's another red flag. If it's been 6 months when you're age 35 and up, now you need to seek fertility help sooner.
So that time shortens. So if after the age of
Shortens.
35,
Yes.
6 months is regular sex,
Yes.
and you haven't conceived, you haven't been pregnant,
Yeah.
then you need to start.
Then, by definition, according to the American Society of Reproductive Medicine, you have infertility. Now, they've recently changed the definition to be more inclusive. Traditionally, it's the 12 months of unprotected sex, under 35, 6 months, 35 and up, or if you already have a known diagnosis that can cause infertility. For example, if you already know you have blocked fallopian tubes, you should not be doing the 12-month wait. You need to go get treatment right away, because with blocked fallopian tubes, or if you've tied your tubes and now you want another baby, you know you need to do IVF. That's the only way to circumvent the fallopian tubes, because that's where naturally fertilization takes place. If there's no tube available for fertilization, we have to do IVF. But if someone has irregular periods and they can't even track their ovulation, then you should go in sooner as well. And also with the new definition, if there's any circumstantial reason that could make it difficult to conceive. So if you are single wanting to be a parent, or if you're in a same-sex couple, or you're transgender going through hormone therapy, then you need to go in and get treatment sooner. These populations already know this, but the definition has changed primarily in hopes that insurance companies will start covering other scenarios to help people build their families.
We've mentioned the word fallopian tube. We've mentioned the word ovulation.
Yeah.
In a genetically born female, can you describe the reproductive organs?
We're going to start with the ovaries. The ovaries contain your eggs. That's where you ovulate from. Let's go a little bit deeper into that, because these are important things for people to understand. Is each egg has its own container called a follicle. You are born with all the eggs you're going to have in a lifetime. They are all in the ovaries, and each one has its own follicle. Most of them are in the resting stage, so they cannot be seen. And then the ones that are available for ovulation or stimulation are at the surface. They look like these little black bubbles on ultrasound. Then you have your uterus, which is connected to your fallopian tubes, and lower down is connected to the cervix, which is inside the vagina. The cervix has a canal, which is an opening that leads to the uterine cavity. The uterus is where implantation takes place. Higher up where the fallopian tubes are, that's where fertilization takes place. So when you ovulate, the fallopian tube picks up the egg. If there's sperm there to help fertilize it, fertilization happens in the tube, and the developing embryo migrates through the tube into the uterine cavity, where implantation will occur, and hopefully there will be a baby growing in there one day.
So there's some common misconceptions with infertility, and there's things that are said that I don't necessarily like or agree with. But the first thing, and I just want you to comment on it, is somebody might say, and I remember saying to some of my friends' wives, they'd say, "Oh, just relax, you'll get pregnant."
Yeah, common misconception. It's crazy, because infertility is not a mindset, it's a disease. There's pathology. Now, I will say stress does matter, because we know in extreme cases of really acute, pronounced stress, or even low-grade chronic stress, can impact your menstrual cycles. It can impact ovulation. And we know that because if you have elevated cortisol levels, that can affect what we call the hypothalamic pituitary adrenal axis. And because the same parts of the brain are responsible for your reproductive hormones, anything that affects any other hormonal axis can throw off your reproductive hormones as well and affect ovulation. But usually it will present as a symptom of irregular or absent ovulation. So if you're ovulating very regularly and you're feeling stressed, it is unlikely going to be the reason for failed treatment or not getting pregnant.
Another one, infertility only affects women.
Yeah, nuts, because it affects men half the time. If we look at major causes of infertility, a third of the case it's female only, a third of the case it's male only, and then a third of the time it's a combination of both. And in 15 to 20% of cases, it's unexplained, meaning when you do the evaluation for both partners, everything looks perfect on initial evaluation. So we don't have any real explanation for whether or not conceiving.
Another one is in vitro fertilization is the first and only option. Is
Yeah,
that the case?
not true at all. Not true at all. If someone is not ovulating, you can give them meds to help reinstate ovulation, and now they do timed intercourse, or they just have sex around the fertile window. And then if it doesn't happen after that, then we have to talk about alternative options. If there's mild male factor infertility, it could be something as simple as intrauterine insemination. Unexplained infertility first line treatment is a combination of super ovulation with medications plus intrauterine insemination. So there's all different strategies that we could take before we jump to IVF, but it's really at the patient discretion. So if someone wants to jump into IVF right away because they're like, well, I want to increase my chances of getting pregnant in one given month, IVF will usually give you your highest chance. Or in some cases, we'll even talk about jumping straight to IVF if, let's say, somebody's in her late 30s and wants multiple children. Then we start to have to think about, what do your future offspring, like how old are you going to be at that point? How hard is it going to be to get pregnant? How long is it going to take? So let's consider what your entire family looks like and plan treatment accordingly.
So in vitro fertilization, you're taking one sperm and one egg and inserting the sperm in the egg. Is that right? Or is it?
Yes, but we're trying to get as many eggs as we can in one cycle. So we're trying to improve efficiency, because if I got one egg and one sperm with every IVF cycle, there is a 70% chance of fertilization. So 30% of the time, fertilization won't occur. And this is on average. Only half of the fertilized eggs will become embryos. And then, depending on female age, that will dictate the percentage chance of chromosomal abnormality. And so, if you're older, the chance of one egg making it to a baby is pretty low. You would have to go through IVF over and over and over again. So, over the years, they developed all the injectable medications to try to stimulate all of the follicles available to try to get as many eggs as we can to improve efficiency, increase the likelihood that one IVF cycle will lead to a baby, even if it means multiple embryo transfers. But in many cases, our goal is to even have enough embryos for future siblings as well.
What steps should a couple take before seeing a specialist, or should a person take before seeing a specialist?
Number one, track ovulation so that you understand what your menstrual cycle looks like. What does it feel like when you're ovulating? Do you feel it at all? Do you not? Do you get that cervical mucus? When does your temperature usually rise? Because every woman is totally different. And so it's really important for her and her partner to really be in tune to what ovulatory cycles look like. Additionally, obviously really important to have a good sense of your overall health, improve nutrition, stay on top of your exercise routine. Obviously, we want to reduce anxiety. I'm not just talking about everyday stress. Everybody is stressed. You can't avoid stress, but I'm talking uncontrolled anxiety, depression that needs to be handled, because we know reproductive outcomes are poor in those circumstances.
Basic blood work, I'm sure, checking
Basic
thyroid.
blood work, 100%. So the number one thing is really genetic carrier screening. So anyone before trying to conceive should check their genetics. I catch about 5 to 10 couples a year where they are both carriers for a mutation for a lethal disease. You do not want to find out once your child is born that they're going to die. That is the most devastating thing that anyone can endure. And so if you can at least avoid something very catastrophic from happening, it is through genetic carrier screening and then checking titers. So blood work, checking your immunity against rubella and chickenpox, because if you got exposed to these viruses in pregnancy, it's too late. You can't get vaccinated. There's not much we can do. And if baby is exposed to these viruses, it can cause major birth defects. Outside of that, yeah, you can check your thyroid hormone. That's really important. But the guidelines have actually kind of changed recently,
Oh.
and for various reasons. But even the American Society of Reproductive Medicine doesn't actually recommend routinely checking thyroid function. Now,
Oh.
I do, because I don't want someone to have a miscarriage to then find out that there's subclinical hypothyroidism that may have contributed, but it's always a good idea to check thyroid function and to check other hormones if we are concerned about, ovulatory dysfunction or something.
I was reading something somewhere where it said they want you to do a semen analysis before you see the specialist.
So you could order it at any point in time.
Yeah.
And so anyone who comes in and says, we haven't even started trying, but we really just want to know what we're working with, then you can go to a clinic to do a semen analysis, which I think is great. And then alternatively, you can do at-home semen analyses. And there are companies that really do a great job at it. Like Burden B was developed by a reproductive endocrinologist. And so you can do it at home, send it out, and at least get some basic information about your sperm. And so a lot of the testing you can do in the comfort of your own home. Now, is it same level as doing it in a fertility clinic? Of course not, but we're just talking about baseline knowledge. If you are dealing with infertility, it's still best to go into a fertility clinic, get really thorough evaluation to see what's going on. But this is just more stuff you can do before even starting to try to know what you're working with.
Do you suggest that individuals kind of know their fertility baseline?
I personally think it's important.
Yeah.
It's not necessary and it's not even what's recommended, but you should never have to wait until you have infertility to do the evaluation. If somebody wants to come in from day one and say, hey, I want to make sure my fallopian tubes are patent, my uterine cavity looks normal, everything hormonally is in check, and that sperm looks good, I'm all for it. You don't need any treatment after that. If everything comes back normal, and I do have these patients that come to me that just want the information, we give it to them and tell them, all right, you're good to go. Go start trying. And if it doesn't happen after a year, 6 months, or whatever you decided is a point where you want to come back for treatment, then I'm here.
So I want to connect this back to REI, and I want you really to break it down.
Okay.
I want you to define reproductive endocrinology for all of us.
Reproductive endocrinology and infertility
Ooh, okay. See, I
is
already
the
said it wrong.
specialist.
Okay.
It's funny when I say REI to other medical professionals and including physicians, sometimes I get this like confused look. What is that? So reproductive endocrinology and infertility REI. We're not talking about the store where you get your camping gear. This is the specialty where we are the reproductive hormone experts.
Yeah.
So we do anything entailing your reproductive hormones and also treat infertility. Originally, the specialty is all about managing hormones, and its various diseases will fall under this category, like adrenal enzyme deficiencies, like 21-hydroxylase deficiency. It could be thyroid dysfunction, although that's mostly treated by medical endocrinologists, and that is usually the most appropriate person to go to. But menopause, contraception, and then infertility.
When we open up Instagram, when we open up social media, anything, every other post is about, perimenopause and menopause and treating it. And
it's trending a lot lately.
Oh my gosh, it's
like
trending
crazy.
so much. And it's fine. Like, I got no issue with it. Like, yes, take all the hormones unless, you're like my wife who had breast cancer and you have to have them inhibited for good reason. But like, it seems to me that, I don't know, perimenopause, menopause should be managed by, I don't know, the reproductive endocrinologist and infertility specialist. But it seems to me like it's obvious. But like,
yeah,
I don't know why other people don't take it that way. Like, I feel like you guys should be managing it. This is what you do every day. It's kind of like, I'm a pulmonologist. Like, I should be managing the patient's asthma. Like, I don't want them going to see an OB-GYN. Like,
true.
You guys manage that, right?
The problem is with our specialty, which has sort of become more of an industry, I will say, for better or for worse, most REs are more focused on the infertility aspect of the job rather than the reproductive endocrinology. And the main reason is most practices are private practices that are now owned by private equity or backed by VC, and it's the moneymaker.
Yeah, people pay cash for fertility.
Yes, it is mostly cash pay. Insurances are barely ever involved, and the ones that do cover, most of them will have pretty good reimbursement. Some don't have good reimbursement, and as a result, a lot of the clinics won't even accept it, which, is a problem. insurance obviously has a lot of problems. We know this. But the downside is, even if you're someone who's passionate about it and you want to treat it and you want to do it, the jobs that will take you and have you do a lot of the repro endo stuff just don't pay nearly as well.
Yeah.
And so it's really unfortunate that this has become the case, because now you have people of other specialties who call themselves hormone experts. But the reality is, the amount of training we've had to go through. I mean, we did 7 years of training, 7 years, and then 2 years of board certification. And the only reason why I'm able to maintain all of my knowledge from the reproductive endocrinology side is because I actually write some of the board exam questions.
Yeah.
And so I have to stay on top of it, and I do that voluntarily on purpose to stay on top of that knowledge. But I agree that it's a problem. You will mostly see that in academic centers. So if you go to a university institution that has an REI division, you will have the reproductive endocrinologist who will be able to manage all of your hormones in a way that probably most other physicians will not, because the depth of knowledge in the specialty supersedes everyone's. No offense. I mean, I will say, like, we have to, in our exams, draw the structure of all the hormones.
Right. Again, we talk about obvious things like, okay, why does REI matter? So 1 in 8 couples face infertility is the number we say, but it's like 1 in 8 couples may face infertility, but I don't know, 100% of women, if they make it to that age, go through perimenopause and menopause. Like, that's why it matters for me. And so, like, I'm sitting here and I'm prepping for this, and I'm like, why isn't my wife going to an REI for hormone management? Like, it should be an obvious thing to me. And it sounds like you're saying the same thing, but you're also being real. Yeah. Okay, listen, like, fertility makes money, and that's what they want you to do, because that's what society has become about for whatever reason. But when talking about infertility, what are the common causes of infertility?
So number one most common cause overall is ovulatory dysfunction. Okay. So the ovulatory issues are for various reasons. It could be thyroid disease. It could be that you have high prolactin levels, which is the hormone responsible for breast milk production when you're pregnant. And if your body thinks that it needs to produce breast milk, it thinks that it has to feed a baby and not make a baby. So that can throw off ovulation, obviously. There are so many other reasons, like hypothalamic amenorrhea, whether it's due to overexercise or eating disorders or major calorie deficit. Various brain tumors can affect it. There's so many reasons, but the most common ovulatory reason is PCOS. Then you also have male factor, which contributes to 40% of infertility. So we have to check sperm. We always have to check sperm. And anyone who comes to see me and wants a fertility evaluation and then wants treatment, if we don't have a semen analysis, we do not move forward with treatment until I have a semen analysis. And some will argue and say, well, I just want the meds. I just want this. I'm like, but I don't even know if there's sperm. We got to check to see if there's sperm. How do we know? So we always have to check that. Those are your most common reasons. Unexplained infertility being like the third most common reason, because that accounts for 15 to 20% of all infertility cases. It doesn't mean there is nothing wrong. It just means that initial infertility evaluation cannot define what the problem is. And this is where IVF is both diagnostic and therapeutic. So we could see, is there an egg quality issue? There are newer studies showing that in unexplained infertility, about 40% of the case will have an association with endometriosis. And endometriosis really negatively impacts fertility through various mechanisms, alters your anatomy, your reproductive anatomy. It can cause scarring of the fallopian tubes, reduced egg quantity and quality, as well as reduced implantation.
Now it's time for What's the Buzz, presented by BuzzRx. Every week, I answer a health-related question from one of our viewers. This week's question: I've started IVF, and my fertility doctor prescribed me Clomid before my egg retrieval. How does it work? Well, Clomid is clomiphene, and what it actually does is it stimulates the follicle for development. So if you increase the stimulation of the ovarian follicle, you're going to have more eggs. The other thing it does is it supports ovulation. So when you ovulate, you have more eggs, hence the egg retrieval. That's the buzz. If you have a question, email us at healthexchangepodcast@gmail.com. Thanks again to BuzzRx. Look up your medications on buzzrx.com or the app to see how much you can save. And what's endometriosis? Isn't that where the endometrium is elsewhere in the body other than the uterus? Is that right?
So recently, the definition has changed. It used to be endometrial glands
Yeah.
are present outside of the uterus, and now it's endometrial-like glands
Mhm.
present outside of the uterus. So tissue similar to the lining of the uterus is present outside of the uterus, and the reason that has changed is because we now know that some endometriosis implants in the body are not only hormonally mediated, they produce their own hormones to feed themselves, kind of like a cancer.
Wow.
Not cancer at all, but it just behaves very differently. The ones that are very affected by hormones that are produced by the ovaries are much easier to treat because if estrogen is feeding it, you suppress the estrogen, you can control the endo, but that's not always the case for everybody.
Walk me through that typical visit, first steps. What are you saying? What do you want to accomplish with the first visit? How does it move forward from there?
So everyone is a little bit different, but for the most part, it's kind of the same where the first visit is an initial consultation. I personally spend an hour for every initial consultation because it's important to also educate. So you get the history. Most of the time, we actually have them pre-fill it before they even come in
Mhm.
so that I know as much as there is to know about their history and menstrual cycle, reproductive history for the male partner as well. And then I run them through what the initial evaluation is. And I break it down simply in the sense of we know that we need eggs, we know that we need sperm, and we need normal female reproductive anatomy to make a baby.
Yeah.
We need open fallopian tubes and a uterine cavity. So the initial evaluation reflects that.
Got it.
We need to evaluate egg quantity because that can influence the treatment that we're going to do. And we do ovarian reserve testing through both blood work and ultrasound. Blood work is AMH, stands for anti-Müllerian hormone. This is a hormone that gives me an idea of where do you stand in terms of categories. Do you have an abundance of eggs? Are you above average? Are you in the average category? Or is your ovarian reserve so low that we actually need to be worried a little bit? But this does not actually correlate with likelihood of pregnancy. It just reflects, medication dosing and et cetera. And then the ultrasound, we're looking at your follicle count, what's called an AFC. The antral follicle count is how many follicles, each containing one egg, is available for stimulation in a given point in time. But this number does fluctuate throughout the menstrual cycle and it fluctuates month to month. They're different between the right and the left side, so they're not always the same. So we start with that with the eggs and then also look at ovulation tracking. So hopefully the female patient has been tracking her ovulation. And so I have a sense of is there ovulatory dysfunction or not.
Got it.
So if they tell me, oh yeah, my periods are every month, like I got it in the beginning of September and then the end of October, that's a red flag. But if someone tells me it's every 28 days on the dot, like I know exactly when my period's going to start, that's great. I know that she's ovulating. And then in terms of anatomy, we do an HSG, which is a hysterosalpingogram. That's where I place a catheter in the uterus. And then under X-ray visualization, I
Some contrast in there.
throw contrast in there and see if it fills in the tube and spills out. And if it does, then I know that the shape of the uterus appears normal or maybe abnormal, and then the fallopian tubes are open. It's great for uterine cavity assessment as well. However, it's not as sensitive as an ultrasound to detect things like fibroids inside the cavity or a polyp or any scar tissue. So this is where ultrasound with contrast in the uterus is also important. I personally actually do both at the same time so that the patients don't have to come back in another menstrual cycle, go through a second procedure that's similar. I have an ultrasound in the x-ray room, and so I do kind of a 2-for-1.
You do transvaginal ultrasound?
Transvaginal
Yeah.
ultrasound, yeah. And then finally, for the male partner, a semen analysis tells us a lot of what we need to know from the male side.
I have a basic question. I'm going a little bit off script here.
Cool.
If a male has a sperm count and it's low,
Yeah.
can you stimulate the sperm count to be higher? Like you can stimulate follicle production? Is there a medicine that you
Sometimes,
give?
yeah. So it depends on the cause. So the semen analysis is a screening tool. So if the semen analysis comes back normal, then we presume that sperm is normal.
Yeah.
Now, if there's a history of recurrent pregnancy losses, it could be that the semen analysis is normal, but there's a lot of oxidative stress, and this is where we could do further testing like DNA fragmentation index.
Mm-hmm.
But if the sperm parameters come back abnormally low, so low concentration, low motility, we're looking at 100 sperm out of millions. So it could be a coincidence that 100 sperm
Just
doesn't
look
look
black.
that great.
Yeah.
But if the concentration and motility is fantastic, then I know that we're in good shape. But if it's abnormally low, the next step is to check testosterone. It's to check other hormones like FSH and LH. So people think of FSH and LH only for the women. FSH recruits the follicle or the egg that's going to be ovulated. LH helps to release the egg. And when you use ovulation predictor kits, what you're actually detecting is the LH being secreted in your urine. But in men, FSH is responsible for sperm production, LH for testosterone. And so these gonadotropins are really important in the signaling that's necessary for intratesticular testosterone production and sperm production as well. And so if those hormones are off, you can sometimes treat it. The treatment is not testosterone ever. If you're trying to get pregnant, or anyone who thinks they want to get pregnant in the future, who is a man, they should not be taking testosterone because they completely inhibit sperm production because of that negative feedback to the brain. So in those cases, we can give medications like Clomid or letrozole or anastrozole. So same medications women get for ovulation, men can get to improve sperm production. And in some cases, like, this is a mouthful, but hypogonadotropic hypogonadism, meaning the brain is not sending the signals, but from before puberty, and that caused boy not to really enter puberty, then you would actually have to give injectable gonadotropins in those cases. Sometimes we do have to give that as well in the case of reversing what testosterone has been doing. So a lot of guys will come to me saying, my doctor put me on testosterone because I had low libido and fatigue. And I'm like, your doctor knew you were trying to get pregnant and gave you testosterone? Yes. So for me, it just kind of drives me bonkers because in most cases we can reverse it, but it does delay time to pregnancy by 3 to 6 months. But in some cases, we try to reverse it and the sperm just never looks the same. It does not look good.
That is like super interesting. I did not know any of that. So you taught me something that I can bring into my clinical practice because I got a lot of guys that ask me for testosterone.
Yeah.
And so now my question is going to be like, are you trying to get your spouse pregnant? Because if that's the case,
or
like,
will you in the future?
or will you in the future? Because if
Yeah.
that's the case, then we're not doing this.
Yeah.
So I actually appreciate that.
Yeah, I'm glad.
But now what I want to do is I want to do fast fertility facts. All right.
Okay.
This is supposed to be fun. This is going to be great. All right. These are going to be quick questions, quick answers. This is fertility fast facts. All right. Tell us about the biggest myth about in vitro fertilization you wish patients would stop believing.
It works the first time for everybody. Just do IVF and you'll get pregnant. It is very dependent on age and diagnosis.
Literally, how much does sperm cost?
Insanely variable. It can cost as little as $1,000 a vial. I shouldn't say as little, or as much as tens of thousands if you are trying to be matched with a sperm donor that you will know who they are.
So like knowing who they are increases the cost, or is it like you're getting
if it's
Will
through an
Smith
agency.
sperm? So like
if it's through an agency and then you start the negotiation process. I want you to fly to this clinic. We'll pay for your flight, your hotel, your accommodations. I want you to do this, do that. So it could be as simple as going to a sperm bank, paying for a vial. And there's different vials, right? Whether you're doing intrauterine insemination versus IVF. Like you can get IUI premium, which is $2,000. And you can be the one who says, I want to be the only person who gets this donor. And now you pay an extra premium to make sure that they do not sell this sperm to anybody else.
But I mean, like they still could. Like, you know,
Of
you're not
course.
there all the time.
They could, yes. And I mean, there's
I'm
all
sure.
sorts of scandals. I don't know if you've seen like the Netflix documentary.
Yeah, but somebody that had
I forget the title of it. It's like Man with 1,000 Babies or something.
yeah, something like that. It's crazy.
Yeah, horrible.
What's one supplement you think is completely overhyped for fertility?
Chasteberry or Vitex. Oh my God, everyone talks about it all over social media.
Vitex?
Yeah, it doesn't do anything. It doesn't do anything. There's no point. Just take a prenatal. Call it a day. And some antioxidants like CoQ10, NAC. There's a lot of good antioxidants out there.
So N-acetylcysteine is good.
Yeah.
CoQ10 is good.
Yeah.
Prenatal vitamins.
Yeah. Vitamin D if you are deficient.
Vitamin D if you're deficient. All right.
Yeah.
What's one lifestyle factor that patients underestimate in its impact on fertility?
Sleep. Sleep, sleep, sleep. Foundation of health. Everyone underestimates the importance of sleep.
I hate when people tell me that.
I know, and we all have bad sleep as doctors, and it's so, so terrible for longevity, for your overall health, for your mood, but it's also important for fertility because most of our hormones are diurnal, meaning when we go to bed, this is when the brain is working on secreting these signaling hormones. And if we are not sleeping properly, it can disrupt it. We know that even things like melatonin can throw off your gonadotropin release and pulsatility. So,
Egg freezing, best done in your late 20s, early 30s, anytime?
best time to freeze, late 20s, early 30s, most bang for your buck. But if you are, single in your late 20s, you're worried about it, you don't have to panic. You really have until 35 until you're really getting that cost effectiveness.
Do sex positions really matter when it comes to conception?
0, not at all.
No.
You don't have to lay down after sex. You don't have to raise your legs. You don't have to change positions.
Handstand?
Yeah, they're swimmers. They swim. They actually have to push through cervical mucus pores, which are microscopic, to make their way into the uterus. The sperm that makes their way to the uterus through natural conception are strong.
What's the weirdest fertility myth you've ever heard from a patient?
Oh gosh, there's so many. Where do I even begin?
Funny, weird, like you were like, what?
I mean, I would say the weirdest things are just like weird nutritional things that people have heard, like specific eating the pineapple core has become a really popular one, or eating McDonald's fries after you've done IVF, which is literally the most unhealthy thing. So I'm like, don't eat the fries from McDonald's, please. It's just not good for you. I think those are like the weirdest fertility myths that exist that have become very trendy, and almost everyone does them.
Where does it come from? Where does the pineapple core thing come from? Are you like, where the hell did this come from? Or is it
Instagram, I think, or social media. I don't know. I think it's just random influencers who put that out there, and
I just
it
always
just stuck.
I just always wonder the origin of these things. It's just I
Yeah.
find it really funny. If you had to pick one, I think I know what you're gonna pick here. Nutrition, exercise, sleep, or stress management, which matters most for fertility outcomes?
Oh gosh, all of them. All of them. But I would say probably nutrition more than anything. Yeah.
What's the first question you hope new patients ask you?
Teach me about the menstrual cycle. I want them to really understand what they're doing, so that they can make informed decisions. The most common problem I see from patients is they sort of go with whatever they've been told. They have no idea what's happening, and therefore they can't really take ownership of their treatment and participate in shared decision making.
Have you ever talked somebody out of getting pregnant?
No, I don't feel like it is my position to do that, aside from medical contraindications. So, from a social perspective, no, but from a medical, yes. I have turned down one patient once. She was in her 50s coming back for her embryos and had sort of a second wind, wanting the rest of her embryos transferred, but her blood pressures were extremely, extremely, extremely high every time we measured it in the clinic. And even though somehow she got maternal fetal medicine clearance, so high risk OB cleared her for an embryo transfer, I declined and said, if you want a gestational carrier, I'm happy to do it. I will not transfer an embryo in your uterus because I think that you are putting your body in harm's way and you already have kids.
A gestational carrier meaning a surrogate?
Correct.
So do you have like surrogates on speed dial that you just call? Like when
No, they usually go through agencies, and then it takes about anywhere from 6 months to 12 months to get matched with someone. It takes a while, and it is a very expensive endeavor.
I was gonna ask, how much is it?
At least 6 figures. Most agencies will charge about $140, $150.
And so they probably take half and give half to the person that's carrying.
Well, they do a lot of the legwork. So getting legal involved for contracts and negotiations, all of the FDA requirements, doing all of the evaluation for the gestational carriers to make sure that they are actually eligible before going through with it. Because if you find someone and you bring them to me, now you have to pay for all of their evaluation. And if they are not fit to be a gestational surrogate, and we turn them down, you are now thousands of dollars in, starting from scratch.
Best way to emotionally cope during the IVF process?
Therapy, community, meditation.
What's one underrated resource or support system for patients going through infertility?
I would say definitely the support groups online, finding your tribe who's also going through the same thing you're going through, because unless you're in it, nobody else understands what you're going through.
If you had to describe IVF in just 3 words, what would they be?
Stressful, costly, effective.
Very nice. Your number one piece of advice for someone just starting their fertility journey?
Hang in there. There's going to be highs and lows, things that you will not predict along the way, but it's the people who are the most resilient and they just push through that eventually will get their happy ending. And having been through it myself, I promise you it's worth it. It really is worth it.
If you don't mind me asking, how long did you have to go through that journey before you conceived?
So I did 6 treatment cycles, not of IVF. So I already knew that I had infertility before we started trying because I did not ovulate. So I have a rare form of non-classic or late onset congenital adrenal hyperplasia, which is an adrenal disorder that causes me to essentially not ovulate. It sort of mimics PCOS. And so I knew that I needed treatment before we ever started. We had previously done IVF for fertility preservation purposes, which I will say to all women, unless you are in a happy, committed relationship, knowing you're going to have an embryo transfer in the next couple of years, do not make embryos with your partner. Even if you love them, just freeze your eggs. So, because I see so many people coming back, divorced, something didn't work out, and they're older, and now they have to freeze their eggs and do so many more cycles to make up for it because of the age-related component. But we did IVF for fertility preservation because I was 32, and it was covered for me. And I knew that we were going to start trying in 2 years. We did multiple cycles of ovulation induction. I was monitoring my cycles, taking trigger shots to know exactly when I ovulate, and even doing inseminations because I have the luxury of it at my disposal at work. And 6 cycles did not work. They were unsuccessful.
Is it a cycle a month?
A cycle a month because I did back-to-back
Mhm.
cycles because I was not taking breaks in between.
Yeah.
So then we eventually decided to do an embryo transfer, which was successful the first time, which was very lucky. Given the age they were created, I knew it was a 65% chance of success, and I was lucky to be in that 65% category.
So it sounds like, as far as the treatment pathways you went through kind of different treatment pathways.
Correct.
So you do this every day,
Mm-hmm.
and you've been through it yourself.
Yeah.
Like, emotionally going through the process. And I know you have 2 kids, but you went through the process once, right?
Correct. Once.
What was it like dealing with, I'm sure there was emotions involved,
Totally.
and how has that helped you in your practice? I'm sure it has.
Funny enough, the first clinic that I went to, it was a really bad experience as the patient. And I couldn't believe it because I was an REI fellow and they knew I was a doctor in the same specialty. I didn't go to my own program for treatment because I'm Canadian and it was covered by Ontario Health Insurance. So I went back to Canada to do it there. My fellowship program didn't even give us a discount, believe it or not. So, and in your training, you can't afford treatment like that. Yeah, it was a really, really bad experience. I couldn't get in touch with them. They missed a lot of things and they just treated me terribly. I mean, at one point the sonographer yelled at me because she was like, "You have to have a full bladder." And I said, "No, I don't. I do this for a living. I know what I'm talking about. What are you talking about? You don't need an abdominal ultrasound." And it turned into a whole battle. And luckily, one of the neighboring clinics, he was actually hoping to hire me. And so he was like, "Don't worry, I'll take over your care and we'll make a much better experience." So I had a bad experience and then a good experience, but
In the middle of you going through
in
this,
the middle
you
of
were
me going through this, I totally just shifted to the next practice. It helped that I was doing this. And so while I was already starting medications, it was much easier to sort of lateralize. And so I was lucky in that regard, but it really shaped how I want my patients to experience going through this. Because one of my biggest pet peeves is like, I tell my team, you have to respond to patients within 24 hours. They cannot be wondering what to do next. Everybody's anxious. Everybody wants a baby yesterday. There's a lot of money on the line. There's a lot of feelings as they're navigating this. Some patients more than others, obviously, because everyone's journey is different and their background is different. It definitely helped because I can at least relate to my patients from like, this injection sucks, this injection burns, be prepared for this. The bloating is gnarly after the egg retrieval. And so there's a lot of relatability there, which my patients really love because it's nice when your doctor has kind of been through it
Yeah.
and they know exactly what you're going through now. And then the emotional aspect of it, you just tend to spiral. Like you overthink a lot of things. I remember trying to control my husband's lifestyle a lot. Like, you're 50% of the DNA. Like, get your ish together. I'm a fertility doctor. I know better. And he was like, my God, this is so stressful and annoying. And, I just had to dial it back a little bit. But it's really interesting trying to help support heterosexual couples versus, say, for instance, same-sex female couples, which I see a lot more same-sex female couples than same-sex male couples. But the women really are good at supporting each other because they know, like, they get it. Like, they've both had to do speculum exams and pap smears, and so even if there's only one partner going through the injections or, the embryo transfer, whatever they decide to do together, because there's many different ways of doing it, they tend to be pretty good at supporting each other without creating any real resentment there. But I think with heterosexual couples, what tends to happen is there is that female resentment of like, I have to do all this, and then I have to carry the pregnancy, and all you did was ejaculate into a container. And so the
I
least
feel
you
like you
could
rehearsed
do.
that. I feel like you know how to say that really well.
I may have said that a few times. But it's I think you just start to realize like, okay, well, the men can't physically do any of these things physiologically, and that's why they're not doing it. So let's try to find ways to support each other that makes it feel a little bit more fair, if you will. I mean, it's never
So
going to
with
be
that being
fair.
said, do you think that you going through it is more beneficial for the in a heterosexual couple for the female patient or for the male patient? Because I feel like when you tell that story in front of both of them, I feel like the male gets a little relief. Like, "Phew, I'm glad she said it." Like, like it's like if I could help you, like I totally would do it. I'll take
Yeah.
the injection,
Yeah.
but I can't. Like it
Yeah.
feels. Yeah, I feel like you going through that really helps out both of them. Really,
Yeah.
not just
Yeah.
the female who's getting the injections, but
I think it's just about vocalizing what your needs are. And I think also a lot of times the women need to hear that they have to vocalize it. I think the biggest problem is assuming that they should just know. Just saying something simple like, you know what? I'm really physically feeling all this. I need you to take care of me in this way. And I know that it's like an extra mental load of you to think about how someone can support you, but it's kind of the only way to do it. You have to figure out how someone can help support you in order to get that support and just verbalize it. And so it is helpful having gone through it to at least express to my patients, listen, you guys are in this together. This should bring you closer and not make you have this rift between you because at the end of the day, you found each other for a reason. You both want to have a baby together. And this is sort of the first step in creating a family because it doesn't get easier when the baby comes. If anything, it gets harder because now you're trying to navigate raising humans coming from two totally different backgrounds now.
God, you're very soothing. Here's a question for you though. Your oldest kid is 2, right?
Yeah.
And you've been practicing for 5 years.
hmm
Do you think you're a better REI today after going through all of that than you were when you first came out?
Yes. I also just think I'm a better REI ever since becoming a mother too. And I know it sounds a little cliche, but after having gone through the injections, multiple failed cycles, meanwhile, my friends around me are barely trying, and oops, I accidentally got pregnant, and I never got to have that story. I never got to have that surprise, like pee on a stick, tell my husband, oh my God, I can't believe we're pregnant. Like we didn't have that experience. It was very much known, and you spiral when you're not getting that experience. But then once you're on the other side of it, and you hold your baby for the first time and your heart just like explodes. It grows in ways that no one can ever put into words. And I remember my friends telling me, I can't wait until you get to experience that because you'll get it. And we can't have that conversation until you get there. But once I got there, it made my mission even more important. Like, I now got to experience this, and it is the best thing in my life. And I want every one of my patients who comes to see me to have this experience too.
That's really cool. This has been great. Like, honestly, opening everybody's eyes to infertility, reproductive endocrinology, and really understanding individuals from the aspect of, I didn't get to have that pee on the stick moment, we'll call it, right? I mean,
Yeah.
that's just like, it brings a lot of light to this situation, which I think is really amazing. Typically, we end the show with a positive pulse. We want to talk about something or someone that happened in your practice, in your life, that is very uplifting and positive. Do you have a story for us at all?
I do. I actually have a patient who is much older, but she came to me wanting to use her own eggs, even though she has really diminished ovarian reserve. And I counseled her and I said, like, how hard do you want to work at this? Because if you're determined to do this, we'll probably get there, but it's going to require a lot of resilience, a lot of persistence, and possibly a lot of IVF cycles. She stuck through 12 cycles until she got to her baby.
Wow.
Yeah. But we got there. Her own eggs. She was told by other doctors, you need donor eggs. You are not going to get there on your own. It's just not going to happen for you. And I hate to have these statements as a physician, like, what do we know? Like, people can get pregnant. You can get pregnant with your own eggs. It may not happen, but it may happen, and we just got to try. We tried enough times, and it eventually worked. And she finally built the family that she always dreamed to, even though she was of more advanced reproductive age.
Dude, that's an amazing story.
It's the best ending.
That's a wonderful ending. Where do we find you?
So you can find me on Instagram and TikTok at Sasha Hackman MD, as well as on my podcast on Spotify, Apple, and YouTube at Trying to Conceive with Dr. Sasha Hackman, as well as my website where you can see it all at SashaHackmanMD.com.
Perfect. Thanks you guys for watching and listening. We're on at the Health Exchange podcast on Instagram. Find us on YouTube. We're on Apple, Spotify, iHeart, everything. Get us wherever you get your podcasts. We'll see you every Thursday at 6 a.m. Pacific, 9 a.m. Eastern time. We'll see you next Thursday. Thanks for watching.